that's great. So that leaves it to me to introduce and welcome everybody. Welcome to the HCV Action Hepatitis C Reinfections and Harm Prevention webinar. I'm delighted to be able to facilitate this today. Reinfections, harm prevention, really important that, that we have these sessions now. We are about to reach, so at the end of March next year, we'll be reaching the 3rd year of the elimination tender. We have another 2 years, but if we're going to reach our elimination goals, we have to be looking at reinfections and harm prevention. We have to understand more because when we're looking at the maintenance, once we've achieved elimination. And I think that what will come through today is that we actually don't know much about reinfection in this country. We know, and we've had a little bit of information that's come out of Scotland and Tayside, where there's been a lot of reinfections. But I guess the thing is that if there are reinfections, then at least we're treating the right people. But we need to be able to understand more. So I'm delighted today to be able to introduce 4 great speakers to you. So hopefully we can find out a bit more and have a bit more of a discussion. Very quickly, a bit of housekeeping. The session is being recorded, but that's just so that it can be written up by the HCV Action team. If you have questions, please put them in the chat box. I'll try and monitor, and then there'll be some time after the presentations for questions from all the people presenting. So I'm going to kick it off straight away, and it gives me great pleasure to introduce to you Dr. Ruth Simmons. Ruth is an epidemiologist, works for the UK Health Security Agency, what was PHE. And when it comes to stats and data, Ruth is the person to go to. So it gives me great pleasure to hand over to you, Ruth.
Thank you. Yeah, brilliant, wonderful. Thank you so much. That was like you read my mind. Yeah, so thank you so much for inviting me. As Rachel said, this is a fairly unknown subject at the moment, so it's sort of early days in how do we develop ways of monitoring reinfections. So I'm going to run through some of the developments we've been doing at UKHSA and some of the initial methodologies, and it's a ever-moving target, so bear with us. But I also wanted to say that it's Matthew Hibbett who's been doing a lot of the analysis. So please, if you have any questions later, do email both of us and we will help as much as we can. Next slide, please. So as we've just said, so I think I'm going to do this slightly in a different and I've seen a typo already that it says vital, it should say viral hepatitis, although it could be vital hepatitis. So we're on the move since 2015, the introduction of direct acting antivirals. We've been doing so much case finding and trying to increase the coverage of treatment and working towards the WHO's aim to eliminate viral hepatitis as a public health threat by 2030. But, you know, treating a virus doesn't mean that we have changed the behavior that goes alongside that, thinking about injecting drug use, etc. So those who have cleared the HCV infection may also still be at risk of a reinfection. What we don't know at the moment, as we've already highlighted, is that we don't really sure what the extent reinfection does occur amongst those who are treated for Hep C or cleared the virus, spontaneous clearance. We don't know how long afterwards, and we don't know what risk factors are associated with the reinfected population. And so that's what we're all starting to look at in different ways, and many of us will be talking about today. Next slide. So there's not just one piece of work happening simultaneously. There's a number of pieces of work. So NHS England, Graham will probably talk about this later, is looking at doing a cohort study of HCV reinfection after treatment, so following individuals. We are in discussions in-house about how we can enhance laboratory testing to identify new infections, both like reinfections and incidents. So thinking about avidity testing, but also doing whole genome sequencing to look at clustering of infections, and also to be able to define a reinfection going from one virus to a different virus. And then also is the possibility of using national surveillance to monitor new infections, and then also looking at how these individuals are then relinked into the HCV care pathway. Next slide, please. So this is what we've started to look at, and it's very preliminary. We have a database of patients receiving treatment between 2015 and 2021. And this was our baseline. And this is the information entered by the operational delivery networks of the individuals in the area that have been referred to them and available for treatment. So we linked that information to the sentinel surveillance of bloodborne virus testing. This isn't national, but it gives us a snapshot of testing within most areas of England. And this is all testing, not just their first one, so we can follow an individual throughout their testing pathway. And so we looked at identifying any testing that was happening post-treatment. Because nothing is ever straightforward. There are gaps in our data and sort of questions that kept coming up. So at the moment, we've defined 3 methods to use to identify a reinfection. And then we've also looked at looking at factors associated with reinfection and how this compares a positive, a reinfected case compares to those who continue to be HCV negative. Next slide, please. So the 3 methods so far, and as I said, this is preliminary, so it would be great to get feedback and help with developing it. Method 1 was an individual has a treatment start date. They have a treatment outcome of SVR within the treatment database. And then they have another HCV RNA positive test greater than 213 days after their treatment start date. And we kind of went with this thinking about giving them enough time to continue risk and get reinfected, but also that treatment start date may move slightly. It may be that they're giving their treatment and they don't actually start it after a couple of weeks. So we're still in discussions about kind of trying to refine that time frame. Method 2, again, treatment start date as a baseline. And these are individuals who haven't got an SVR outcome within the treatment database. And we tried to look at whether they had a negative RNA greater than 182 days after their treatment start date, and then have a positive RNA 30 days after that negative RNA test. And then the third treatment is actually using the data within the treatment database, which is they have a treatment start date, they have an SVR outcome, and then a subsequent treatment start date greater than 168 days after their initial treatment start date. So they basically got 2 treatment start dates within the treatment database with an SVR outcome in between. Next slide. So with method 1, which was an SVR outcome and then another positive RNA after that SVR, we found just over 1,000 individuals. With method 2, which is a negative RNA and then a positive RNA, we found 618. And with method 3, having 2 treatment start dates within the treatment database with an SVR in between, we found 343. And there was individuals crossing the different methods. So we ended up with 1,336 individuals with just over 600 crossing different methods. So if we looked at all the treatment database, that's a proportion of 2%, but this would be a huge underestimate because not all those people have, not all those individuals have had a subsequent test, so we don't know whether they are a true reinfection or not. And about 25% of individuals who were in the treatment database go on to be continually tested. And so if we were to look at those who had a subsequent test, the reinfection proportion was actually 8%. So if we go on to the next slide, which is factors associated with being a reinfection. So we're seeing a reinfection less likely in females compared to males. more likely in the younger age groups and less likely in the older age groups, and the reference group being 45 to 54-year-olds. So ethnicity, less likely in Black ethnicity and other ethnicity compared to white ethnicity, more likely in those who have reported ever injecting drug use. And then we've seen an increase, or more likely in the north region of England compared to Midlands and East, and less likely in London. So that's kind of looking at our preliminary findings so far. We go to the next slide. Thank you. So using surveillance data, we can estimate that HCV reinfection occurred in a small but significant proportion of patients who have received antiviral treatment. This is likely to be an underestimate due to patients being lost to follow-up or not routinely tested, and also to highlight, as many of you know, Sentinel, it doesn't cover the whole of England, but at least gives us a snapshot of what we are working with. Further research is needed to look at subgroups to understand those at risk of reinfection. Next slide, please. So next steps. So thinking about triangulating between the different methods that are underway, so working with NHS England to triangulate with the Cohort study with surveillance data, to link with other surveillance systems. So we've already started to link with the National Drug and Treatment Monitoring System to review their data and our data. Cross-reference with ODNs. I mean, it would be great if there were some ODNs interested in, if we have a list of individuals we've flagged through surveillance data that we think could possibly be a reinfection, to validate our methodology, and then continue to develop the methods. So thinking about introducing genotype as a method to identify new infections, and then also later on down the line looking at whole genome sequencing. So to reiterate the importance of testing and monitoring, so once someone has cleared their infection, if they're still continued at risk, then we should be testing, and that will help us to monitor reinfections. So thinking about what other additional risk information we might want to include. Thinking about geographical mapping, availability of resourcing in an area. So thinking about what needs assessments may be there, why are individuals being still reinfected? Deprivation, population distribution. Is this a high prevalence area for a certain population? Should we be focusing more for needs assessments within that area? And then thinking about supporting the lab aspect, identifying clusters. So if we do identify reinfections and then a cluster that goes with it, is that because there's no needle exchange sources in that area? And then hopefully working with the Hep C Trust, it would be great to, I know there are peers on the ground, to look at investigating barriers and continued high-risk behaviour through qualitative work, which would be really supportive and interested. And that's it from me, really. So that was sort of a preliminary look into what we've started to look at within national surveillance, and it would be fantastic to get some feedback, and if anyone would like to work with us, it would be fab to validate and expand. Thank you.
Thank you, Ruth. And that was great. That really laid the foundation of the issues. I think for me, when you were presenting, there was the geography. It didn't surprise me, actually, Newcastle.
Yeah.
But it's really interesting, and it has to be, I think, just before I hand over to Stuart, just wanted to quickly say it has to be around the harm prevention stuff and looking at the wider picture and what's involved. And I'm going to introduce you to Stuart Smith next, who's the Director of Community Services, the Hepatitis C Trust. And he's going to be talking to you about preventing infections and reinfections, and hopefully broadening this or delving a little bit deeper. Can I just remind you, if you have any questions, please put them in the chat box, because there will be time to answer some questions later. Stuart, over to you.
Thank you, Rachel. Thank you, Ruth, as well, and all at UKHSA for the very difficult job of getting systems to talk to each other and then making sense of the very large numbers that you deal with there. So I'm going to talk a little bit about our journey at the Hepatitis C Trust briefly to set the scene of where we came from and where reinfections first appeared on our radar, if it was. And then I'm going to talk a bit about what we're doing currently and what we feel might need to happen as we go forward. So if I could have the next slide, please. Okay, so it's worth mentioning that prior to 2014, the Hepatitis C Trust was largely involved with awareness, advice, and advocacy. It was the days of interferon. We weren't pro-interferon, we were pro-arming patients with the right information so that they could make the right choice. And as many of you might well know, it was a big decision to go on interferon. The reason I've pointed this out is reinfection wasn't really a word that we branded around or heard very much. There were certainly there's patients that I've met, my work at the Hep C Trust, who have done interferon 3 or 4 times, but that was often a case of the treatment failing the patient, not necessarily the patient becoming reinfected. And actually, while I'm there, I would just like to say that there's going to be a large presumption going forward, possibly, that patients have reinfected themselves. That might not always be the case. And we've taken a view at the Hep C Trust to try and work out our language around reinfection, because it's possible that treatment hasn't quite worked. We do see people's virus return post-treatment very, very rarely, but we've just got to be careful that we don't stigmatize people too much. So when we got into 2014, I suppose, you know, for the Hepatitis C Trust and anyone who worked in hepatitis C, it was very exciting times. There was a massive generational jump in the treatment, in the, how well it worked, and the reduction in side effects from that. And in 2014, we saw early access being delivered. And I think there was about 500 patients who were very end of life, very severe liver damage, and clinicians were able to go ahead and treat with the new wonder drugs, the DAAs. And then at about the summer of 2015, we were involved in reviewing applications for 22 hospitals to become operational delivery networks. And the reason I'm mentioning that is because I do believe the ODNs have turned out to be a great success from NHS England. And they're a great way for us to sort of get a grip on reinfections. So in about 2016, the ODNs were in place. The drugs became available. And there was, as I said before, there was a sort of national oversight on prescribing, or at least the amount of drug that was being prescribed and where it was being prescribed. So we're now in a position to sort of maybe start getting a picture of what's happening with the new treatments. So next slide, please. So we've got the new drugs. It's worth mentioning that when we first had the guidance and the approval to prescribe new drugs, there was no second chance for treatment. And in fact, this became a barrier, because where before we'd always struggled with people who were still using, should they start interferon? And it could potentially stop someone from starting treatment. And now there were nurses, and rightly so, but there were nurses who worked with patients who felt, you know, don't start treatment at the moment, your life's a bit chaotic and you're not going to get a second chance. So that's worth a mention here. And at the time, I remember meeting a wise old lady I think she's a current drug user, possibly an ex-drug user. And she said to me, once you've done interferon, you think twice about using dirty equipment. And that raised a question for me, is that we're now in an era where it's very easy to take these pills. And in fact, with peer support, they're getting a cup of tea and a few meals thrown in and a bit of company. And so it does raise a question of, you know, where there was so much pain in clearing your virus before, did that make you think twice? And that's something that's up in the air and yet to be discovered, like a lot of questions around reinfection. And when the drugs first arrived, we had the sequins, which many of you remember, which was a payment back to trusts based on quality and innovation, but it was a very large payment, and there were certain criteria that a trust had to fulfill to get parts of those payments. And when the sequin first arrived, we had something called the SVR 48 part of the payment. And that encouraged trusts to retest RNA people post-treatment at 48 to 56 weeks to try and get an idea of whether there was a sustained, negative virus for that patient and that they possibly hadn't reinfected or the treatment hadn't relapsed afterwards. The levels were low, and they were lower than what Ruth just mentioned, but I'm not sure we were still in the real world idea with this, because it was obvious that the people we weren't getting that many SVR 48s. I think it was around about the 50% mark of patients were actually getting tested again further down the line. And common sense would say that those patients were maybe the less chaotic ones who did show up and got an SVR 48. So at the time, when this was all happening, I think the Hep C Trust took a view that drug services were going to take a large part in the treatment and sustained testing that needed to happen if we were going to meet elimination goals. And we also felt that there was going to be a degree of intense activity, and that commissioners really should hopefully commission their services so that anyone in their area was getting put forward for treatment and they could basically clear the hepatitis C pool out of their area. And we actually would talk to commissioners and say that, they don't take any action if there's very little testing done. While NHS England is pushing all the activity, then they could be left, commissioning services with high levels of HCV in their service. So next slide, please. So talking about commissioners who commission substance misuse services, we issued a commissioning toolkit that was based upon what we felt best practice. There was a sort of example spec in there of how many people should be tested, what sort of people should be tested. And the question I've put here on this slide, the first question is there a link between the amount of hepatitis C that people are catching and the reinfection rates, between this and a good substance misuse service that provides great harm prevention, easy to access needle exchange, etc., etc. Common sense would absolutely say yes, but we still don't have evidence. And as Ruth said earlier, I think one of the pictures that we're hoping to start seeing is, okay, well, where the reinfection numbers are high, is that to do with greater testing? So we're testing more people and picking up the people that we want to be picking up and picking up reinfections. And then also, do we need to have a look at that geographical area? Ruth touched upon it, and is it a more deprived area? But also, what are the needle exchanges like in that area? And is there a relationship between harm min and HCV incidents? One of the things that we see in many reports that are coming out at the moment is that the drug-related deaths numbers are higher than ever. I think we've had our highest year reported in the last couple of years, or the last 3 years, highest year on record of drug-related deaths. PHE or UKHSA, who do the UAM survey, are showing an increasing amount of people who have in wound sites in their injection sites. So this is an indicator that possibly, and this is all being done against a background of huge cuts to those services, let's not forget. So, at the Hep C Trust, we are left thinking, well, are we in a climate now where harm min isn't even doing what it should be in those areas? And is that going to work against us? So things like this, how is that going to affect our elimination goals? And we feel quite strongly, we feel that you've got to have good harm min in place. And just as importantly, are we going to leave adequate systems in place post-elimination? So are those services still going to be putting robust testing in place so that we capture people coming in. If it's a reinfection or a new infection, they're straight away signposted to treatment. And that's an important piece of work at the Trust, because there is a lot of activity from NHS England. It might not be maintained, as Rachel said, past 4 and 5 years of the tender deal that has been achieved. So these are all things that we are needing to consider. We've had the Carol Black review, who pointed a lot of holes in the current system. We're not sure how that's going to affect harm reduction services and substance misuse services. And there's a massive shift to integrated care systems, and what kind of role will they play? Next slide, please. So at the Hepatitis C Trust, we've set up prevention groups, and we feel that it is our business to look at what's happening, look at the landscape. We're a very small organisation, relatively. Substance misuse isn't our core business, but we feel well placed to have a look at the landscape and start to work out how it's going to affect hepatitis C and its elimination. 3 of the objectives for the prevention group that's been set up at the Trust are optimal and equitable needle exchange for all, consistent, accessible education and information around safer injecting, and high quality, effective, accessible and individually optimized OST along NSP. And the next slide digs a bit into the detail of how we are going to work that in the Hepatitis C Trust. So broadly speaking, we've split ourselves into 3 working groups. The first working group looks at NSP provision. We've got a large number of peers who are ex-drug users themselves working across England, and we thought that actually we could probably utilise those peers to have a look at what's happening in their area with regards to NSP provision. One of the models we looked at doing was a mystery shopper idea, where peers would actually go in and try and receive some clean equipment and then record their experience in doing so. That was actually born about from the National Needle Exchange Forum, who kindly lent us the model. It looks like we might be going for more of a survey to be done, but we certainly need more information about the current level of provision that's out there, and that's very difficult to get. We're going to campaign for robust and clear reporting, so that's a work in place, and we're also looking at peer-based needle exchange ourselves, and I think Nathan, who's talking in a minute, will give us more information about that intervention. Working group 2, education and information. We already give a lot from our peer service. We deliver that into the prison service. We deliver that in the community. People that we're treating, we are constantly trying to give harm reduction advice to. And we are looking at establishing reinfection related education as well. And then finally, working group 3, the Hepatitis C Trust is working on a reinfections report. We're hoping to have this published by the end of the year, and it's calls for greater evidence. We're including in it some of the qualitative studies that we've actually started at the Trust, and the need to collaborate with partners and more research. So the reinfections report, we hope, will be published just this side of Christmas. So please look out for that. And next slide. Okay, so some of the early findings that the team here have shared with me last week is numerous clinicians were interviewed. We are seeing reinfections in clinic. Clinicians don't think it's a dirty word. It's not a bad thing. If we're seeing reinfections, and it means we're testing and retesting the right people. Clinicians do believe this could be a result of inadequate harm reduction services in their areas or slow diagnosis. So that's another thing that has to be it's all part of the same parcel. If you're not testing frequently enough, then you might not be picking up and putting forward people for retreatment. One of the things that came out of the reinfection report early findings, which were done with interviews, was the need for contact tracing. Treating networks of people is viewed by staff as good for reducing reinfection. And I think that understanding the networks and understanding who people are using with, giving out bring a friend vouchers, they're all going to play a big role in preventing reinfections. Some reinfections will happen. It's going to be part of day-to-day business, I suppose, for clinicians. It's just important that we pick them up quickly. And then I think the last point that was given to me was that areas that see large numbers of reinfections are often around prisons, and this is unclear as to whether this might be because people are screened so frequently now on entry to prison, or whether it's when people leave prison, whether they take greater risks as soon as they leave prison. So again, no real answers coming yet, but we are starting to shape the sort of questions that we need to know. Next slide, please. So I've got these three areas up, not to pick anyone out, but just I think I chose these areas because anecdotally in my travels, we've looked at the Tayside data from Scotland. I don't have it to hand, although I believe it's being published. And when we looked at the data, they had a few thousand people treated, hundreds and hundreds of people back for a second round of treatment with a reinfection, we'll call it in inverted commas, and then some on the third round and some on the fourth round of treatment. So certainly in Scotland, Scotland's very unique in that it's got the entire pathway sits within the NHS services, right down to substance misuse, right down to needle exchange led in pharmacies. So they are able to really get a look of the entire picture, and they are certainly seeing reinfections under that project in Tayside. Leicester and the Northeast is up here because they were flagged by our peers. They were then flagged a little bit by Ruth. And if we actually look at the ODN dashboard under reinfections, there's a pattern starting to be seen. But again, we're not sure whether this is to do with we're testing the right people or whether actually people are getting reinfected at a higher rate in those areas. And so with the Northeast on there, next slide, please. I'm just going to point you to a paper that came to our attention quite a few years ago, actually, and it was a great bit of work by Stuart McPherson in the Northeast. 8,500 people were involved in a study that was conducted. And I will leave you on this slide for just a minute because there's a fair bit of information on there. But essentially, the summary of the paper was that Stuart saw about 19% of those treated, again, for treatment as being reinfected. So obviously, we would assume, we hope, is the very highest end of what reinfection is occurring, but that is close to 20%. Leicester is closer to maybe 5 or 10%, but I'm throwing these numbers out willy-nilly, so please don't record them. But our peers on the ground, I think we've got 4 people being retreated at the moment by our peers under the Leicester ODN. So we're starting to see patterns. Next slide, please. So in summary, certainly we need to know more. I think we're starting to know the kind of questions we want. You know, treating with these new treatments is relatively new. The ODNs are relatively new from a system point of view. But we now have the ability and the oversight, I believe, to really have a look in detail at what's happening and then work out how this is going to affect our elimination goals, what we're going to need to put in place, and where we're going to need to put it in place. So is it in pharmacies or drug services to have robust retesting of those individuals who might be reinfecting themselves. And then finally, the network of injecting drug users. I'm a big fan of Ryan Buchanan's work, and I believe that he might be starting another look into the network of injecting drug users. So he did a piece on the Isle of Wight, but now, so the question for me is, let's say I'm going to choose a town like Barnstaple. Let's choose a town like Barnstaple, where we had about 50 Hep C positives sitting in a drug service there once upon a time when I was working at another drug service. And we know that most of those people probably use with each other, fall out with each other, then use with another one. But there's, it's a relatively small town. There was a lot of Hep C there. And one of the questions I'd like to know is, if you take hepatitis C out of 90% of the people in that town, but you leave it with 10% of the people in the town, so they're still hepatitis C positive, how long, after all our big activity from NHS England, and if we don't put robust testing in place and retreatment schemes, how long might it take for hepatitis C to rear its ugly head and be 30, 40, 50% prevalent amongst the drug users in that town? So there's something about that's hopefully a very interesting piece of work that are going to come out of our research fellows. And I think that Graham's going to talk about a very large piece of work being done across England to try and establish the levels of reinfection. So I'll leave it there, and any questions, again, please put them in the chat, and I'm going to stay on along with everyone else. Thank you.
Thank you, Stuart. I think really important information and really interesting. I think that there's definitely the behavioural, the harm prevention side, and then we've also got the stats and understanding the stats and the data. Sticking with the human and the harm prevention side, I'm going to hand over to Nathan Motherwell now. So Nathan is the Kent Peer Coordinator. And Nathan's going to present to us Every Contact Counts, Delivering Harm Reduction. Over to you, Nathan.
Sorry, I just realised I was still muted there. Can everyone hear me?
Yes, can now.
Okay. So I've based this on my experiences in Kent over the last 3 years. I think it's just about 3 years I've been in post down here. So could we have the next slide, please? So as elimination becomes a reality, clients are becoming harder to treat, to engage and treat, which means it's working. I had this realisation. I went to a soup kitchen to try and find a couple of guys once, and I got there a bit late and everyone was eating and chatting already, and I was watching this group of clients. There's about 4 of them that we treated already that were all chatting, and there was another 2 or 3 there. So I think there was 6 or 7 people that we'd already treated, and 3 that were on treatment, and a load that we tested that were antibody negative. And there was these couple of guys that I was trying to find that weren't there yet, and I realised that they all know each other. Like, everyone at that soup kitchen knew each other. And a lot of them are using together some of the stuff that we've covered already. And the 2 guys that I was trying to find, the 2 guys that I was trying to find were living at the top of a stairwell in a tent and didn't have phones. And you say that, but the sort of what that presents is trying to treat someone. It means that there's nowhere to write to. You can't send them an appointment. And there's no phone to ring to remind them of their appointment, and no way to engage them or support them. And so you literally have to go to the town maybe a week before and tell them they've got an appointment next week, and I bought them a phone and whatever. But it means that as we're getting through people like that, last 10% that we haven't treated, there's a reason for that. It's because they're the most complex clients. And one of the things that I think is really important is we've had a kind of one-size-fits-all service. In a drug service, you get invited to an appointment and you have to turn up for your assessment. And the same with a hospital, you get a letter sent. And and it just doesn't work with trying to treat these people. A lot of this last group of people that are the most chaotic have really complex needs, and it's all different. Some of it's mental health and different things, and we have to adapt that. And I think one of the key things is trying to take the treatment and harm minimisation needle exchange to them. So going and finding them where they are and talking to them about where they're at, what might help most. Yeah, we need to adapt it to meet their needs. We can't do the same thing for everyone. Could I have the next slide, please? So this is an example of one of the guys that's actually finishing his second round of treatment at the moment. So Billy uses IV amphetamines. He's schizophrenic and lives alone, but he often has groups of people at his house that are using. The first round of treatment was unsuccessful at SVR12. When asked, he was adamant that he took his meds daily, but he reinfected himself with his own equipment. So I actually assumed that he hadn't taken his pills daily, because that's the most common thing, is people are so chaotic that they stay somewhere else or get locked up or miss a week or two or a few days. You know, and I was saying, so what stopped you taking your pills every day? And he said, no, I took my pills every day. He said, I think I reinfected myself with my own equipment. I haven't got enough clean syringes. And I talked to him about water filter spoons. I'm going to cover that a bit more later on as well, about how he could reinfect himself and making sure he didn't give it to anyone else by sharing water or, you know, any of his equipment at all. And I agreed to go and meet him every week, and he didn't have any food in his house, so I took him shopping a couple of times, and I went and met him every week, and I still am taking him a load of clean equipment, and he's bringing out all his old stuff every time I go there. So he brings out a bag with all his sharp spins in, and most drug services will only give you 2 packs. They'll give you, you know, 2 packs of 1 or 2 mil syringes, and there's a sharp spin in there and some other equipment. And I think one time I gave him 7. I said, how many do you want? And I gave him a big carryable bag stuffed full of stuff. And every time I've gone there, I've given him 5 packs, and he brings me out a big bundle of the old sharp spins. And so I think one of the things was getting him to have a good clear out. When I first went there, I said, can you make sure you go and clear out everything and get rid of all the old stuff? Because as we know, it can live in a syringe in a closed environment for maybe 3 months. You know, if he was to use one of his old pins from the start of treatment at the end, he could very well be reinfecting himself. And offered refer a friend. I mean, it was a bit more sort of, yeah, well, I turned up one day and there was 4 people there, and I said, do they want tested? And so I tested these 4 people. One of them was positive, and we later got her into treatment. Another time I went there was, I said, you know, do you want to bring some friends around and we'll test them as well? And he rung people and got them to arrive at the time I was coming, and we tested another couple of people. So we ended up testing most of his cohort that he was using with that were regularly at his house. And in terms of harm minimisation, if you can treat the whole group or test the whole group and provide lots of clean equipment and education, and, you know, so I thought that was quite a good example. And he's nearly finished his last month of treatment now, and I just went to see him, took him a load of stuff this week. So hopefully he's going to be cured this time. Could I have the next slide, please? So some of the common issues with this, I mean, we've treated a lot of the people that would turn up. I think in Kent, we've treated between 300 and 400 people that the Hep C Trust have been involved in, and a load more that the nurses have done on their own since I've been in post the last 3 years. And dual diagnosis is a label that we give to clients who might have depression and be smoking cannabis, so they have substance misuse and mental health. But a lot of these clients are unprescribed schizophrenic and using crack and heroin on a daily basis, and actually seem unable to prioritise treatment. And remember, they're not capable some days when I'm talking to people of having a lucid conversation with you, you know, and their lives are so chaotic that they're not only can they not turn up for an appointment, they can't remember to take a pill every day. And high risk daily using routines and practices, a lot of them are putting their lives at risk on a daily basis, injecting in their groin and neck, and that's their life. And a lot of people are very vulnerable. I have one of my clients that treatment was unsuccessful for. He doesn't know how to inject, and so he's letting other people inject him. And sometimes I was told that people are injecting him with coloured water, with tea or other stuff. And so he's incredibly vulnerable. He's also schizophrenic, and treatment failed for him. And I think, in terms of harm minimisation with him, we probably need to teach him how to inject, and to also involve all the other services in his care to make sure he's got people, around him to remind him to take his pills every day and to support him through it. But I think that the key point is there's a much more intense level of support needed for the sort of getting someone their meds and delivering them, and then checking in with them once a week or a couple of times a week is not sufficient for a lot of them. It's not going to work. It doesn't work. And they're also the people that are most at risk of reinfecting people, reinfection themselves, and of infecting others because of the chaos of their lives, because of their mental health issues and a range of different stuff. There's homelessness and lack of a phone, and like being homeless, it presents a lot of problems, like where are you going to put your meds, and the injecting practices. I'm going to talk about that a little bit more in a minute, but a lot of people are using in a stairwell, so they're injecting on a step, on a set of stairs in a car park. It's very high risk of them catching an infection or so one of the things is there's often multiple services involved, and they're not always working together. So a lot of these guys are in touch with mental health, with substance misuse. And for example, in one town like Chatham, it's probably the area in Kent with the highest levels of deprivation, unemployment, homelessness and addiction. And there's the council outreach team, there's Porchlight, there's the substance misuse services, there's lots of different people, and these guys are often known to everybody. Like some of the outreach workers have helped me locate people because they know them and they see them pretty much every day, and the outreach workers are in town every day. But I really feel one of the ideas that we came up with in one of the working groups was about pulling together interagency meetings so that we could all create some wraparound care where we're all involved in meeting this person's complex needs. So making sure that they are prescribed if they've got mental health issues or schizophrenia, or maybe making sure that they're linked in with a substance misuse service and that they've got their scripts. Making sure that we've got needle exchange in place for them, that we can take that to them, and just so that everyone's involved, and then we can all remind each other of, we can liaise with each other. Yeah, I think that's it for that slide. The next one. So harm minimisation, I think, a lot of the time we're not doing this in a little quiet, confidential, one-to-one room somewhere. We're talking to people in the street when we're doing outreach, or we're taking them to an appointment sometimes, and we need very personal information from people in order to be able to work out what it is that they do and get them to change some of it. And so building rapport, and I'm a peer. I had Hep C myself, and I caught that through injecting, and I tell them that first, and also telling them that we don't share this information with anybody else. I'm not working with the police. All I'm doing here is trying to get you treated for Hep C and help you. And we don't, there's no risk really. I'm not going to tell anybody. It'll stay between us and the nurse. But exploring their practices and current situations, what they do, where, with who, how. Always cover water, filter spoons, and revisit this. These two are kind of linked. I don't know if you all know the injecting sort of practice, how it goes. I mean, what people do is they've got a bit of powder, heroin, cocaine, and they have a spoon, and they throw the powder in the spoon, and then they use a syringe generally to draw up the right amount of water from a bottle of water and squirt that on top of the powder, and then cook it with a lighter underneath, and then draw it back up into the syringe to inject. And if you break down an individual person's practice, what they do, it might be that they go to the stairwell and lay it all out on a dirty step. And then who do you do it with? Is there someone else there? It might be that they all draw up out of the same bottle of water. It might be that they draw up out of the same spoon. They normally throw a filter in, a bit of cotton wool or a cigarette filter, in order to filter the gunge out of the liquid once they've cooked it, and then draw up into the syringe through the cotton wool. And those filters retain a certain amount of heroin or their drug of choice. And sometimes people will share them. Someone say, can I have your filters? I'm not feeling well, and they're withdrawing, and they'll throw someone else's filters into some water and cook that again and suck it up into a syringe and inject it. And so if you break down what someone does, you can find where the risk factors are. And something as simple as carrying your own water could reduce the risk, or making sure that you lay it all out on a sheet of paper instead of on the dirty step. Making sure, I mean, the ideal is that someone has all their own equipment, a clean syringe, their own water, their own spoon. But when people are withdrawing, and that's not always practical, that's not always going to happen. So we always cover water filter spoons and revisit this, and yeah, and try and break down, you know, you can apply that same thing for harm minimization to any substance. You can apply it to alcohol. If you look at someone who's binge drinking, you can break down the practice. Who do you go with? Where do you go? How do you get home? What do you drink? You know, and you can change something in that practice as well, making sure someone gets a taxi home or is with someone or with friends, and you know, stuff like that. So tell them what we can offer and ask what might help most. We have limited resources. We can't do everything. I can't sort people's housing out and, you know, their substance misuse issues and stuff like that. But I can refer them into people, and we can get other people involved, and I can sometimes buy them a phone or buy them a bit of food. And so explaining what I can do and asking the clients what might help most. I'm very aware that I personally get into a routine of the type of things that I talk to people about, and sometimes I forget to ask them, like with the guy, Billy, the example. That's not his name, I just called him Billy. But he actually told me I infected myself. I was assuming, you know, that he'd not taken his pills, and that wasn't the case. And I think so. Asking the clients is a key thing. What do you think might help most? What do you need from us in order to get you through treatment? And we don't always do that, you know. So be client-led and person-centered. If they're telling us that they really need help with their housing, let's refer them to housing, and you know, do some of the things. Sometimes people say, when I get my flat, I'll be all right. And I think, no, you won't. You know, you've got a lot of things to sort out, not just your housing. But they get their flat and they are all right. You know, that sort of links into a lot of other things. And so, you know, I don't always know what's good for them, or we don't. Agree in actions and a support plan. So ideally, I think for these most chaotic clients, we need to have other people involved in agreeing that support plan. And one of the things that it would be really good for us to set up, and that we're starting to look at in Kent now, is having interagency meetings where we look at wraparound care and meeting. And it might be we do it because these people are known to everyone. They're getting arrested, they're getting sectioned, they're going to hospital, they're involved with other services. And if we could all agree to focus on a few of these most chaotic clients that are in town every day, or that, you know, that we can't treat, I think we might be able to develop a way between us of getting some of these people through treatment. And it does mean that we're going to be treating less people, right? So as elimination progresses, the numbers fall because there's less people to treat. But they're also the most chaotic ones that need the most support. You know, so it's more work and less numbers, if you like. You know, that's the reality of it. But Yeah, so agreeing actions and support plan and make suggestions and get buy-in from the client. So what parts do you think you could do? You know, I've been trying to get the clients to contribute something, to make sure that they're meeting me somewhere. Like I've bought someone a phone recently, and I said I'll pay for it. It's £6 a month. I'll pay for it to make sure you've got credit on it every month. But what I need from you is for you to answer the phone, or to get back to me, or to stay in touch with me, you know, even if it's just a text, or just to confirm that you're going to be coming to your appointment. Because if not, I'm going to cancel it. I'm not just paying for it so you can score, and, you know, like, and he's agreed to do that. So I've got him committed to putting something into it too. And the last bit is that sometimes there is one small change you can make that can make a lot of difference. And it's that thing. It's, you know, in order to find out what it is, we need to take that time to explore what their daily practices are and what the barriers are for their accessing treatment. Like one guy, I said to him, like, how am I going to get you through treatment? You're always in town and always, you know, what do you need? And he said, well, my nephew lives with me, you know, and that was through asking him what he needed. And his nephew's a bit more stable and lives at the same house, and he goes back there every night. And so I'm arranging a meeting with him and his nephew to get him involved in his treatment and see if he can make sure that he takes his pill before he goes to bed every day. And but yeah, one small change in terms of harm minimisation, I think, you know, what we've done really well is taking Hep C treatment to people in Kent. We've set up clinics in the town centres. We've got clinics we've got one right bang on Chatham High Street. We've got another one right in the town centre of Gravesend, and another one in Maidstone. We've got the bus now. We can drive that to a car park anywhere, and we can get testing people, and it's a one-stop shop. They can get treated. But taking harm minimisation to people as well. I've got a mobile needle exchange in the boot of my car. I've got a locked box where I can take all the returns, and I've got a massive box full of clean equipment, including spoons and citric acid and syringes. And you know, providing that for people, taking the harm minimisation to them has been a massive one. But finding the time to explore each person's individual practices and finding out what that one small change is that can make a lot of difference, you know. Even like I said, I think the bottle of water one is a big one for me, just making people carry a bottle of water. I was thinking lately I might give out little kits to people so they've got their own kit, you know. They've got their own spoon in there and their own little bottle of water and syringes, and give them regular exchange as well. Yeah, but I think that kind of covers it from me. Is there a next slide? I think it says any questions. There you go. Thank you.
Well, thank you, Nathan. I want to use the word sobering because I think that what you presented really clearly is the reality of many of the people that we work with. I think that, you know, kind of Ruth said in her had a piece in her slide about behaviour. You know, it is about behaviour next to the data, and I think there are probably going to be a lot of questions that come through for you in a minute. But I'm going to bring it back to the data just before we finish, because we've got Graham Foster here, who's going to speak to us a little bit about studying reinfections at an ODN level, something that I know Stuart mentioned in his, and the opportunity across an ODN level in terms of collecting data on reinfections. So I'm going to introduce you to Graham Foster. Can I remind everybody, please put your questions into the chat box. Graham is a professor of professor of hepatology, but also works within the national hepatitis C elimination team. Graham, over to you.
Rachel, thank you very much indeed. A bit of a come down following Nathan's global approach. And Nathan, you're absolutely right. We have to have a global approach to this, not a viral centered approach. So slightly embarrassing to be giving the viral centered approach, along with some ideas of what NHS England is trying to do to get rid of this wretched thing. Next slide, please. This is hepatitis C infection. You've all seen this sort of chart before. You're all very familiar with it. This is what happens if you get hepatitis C. Your first sign is that your RNA goes up, then your liver gets inflamed, then you get antibodies, and then you get chronic. And that's all very straightforward. The problem is when you kick the tires on this, it's actually not quite as straightforward as that. And then when you go to reinfection, it's even less straightforward. Next one, please. So the first problem is that some people get symptoms and some people don't. And you're all familiar with Hep C infection, where people feel very unwell. Sometimes they even get jaundiced. And you're also very familiar with people who catch Hep C and don't know they've caught it. We don't know what happens in reinfection. My impression very strongly is that symptoms are much less common in people who get reinfected. There really isn't very much data on that. But I think what we know for sure is that symptoms may or may not occur with a reinfection. We also don't know what happens to your liver when you hit it again. I get very nervous about seeing someone with cirrhosis who's cleared Hep C and is then putting themselves at risk of reinfection. Because we know when you get your first Hep C infection, the liver inflammation goes up quite dramatically. What happens if you get reinfected and your liver's borderline? I don't think we know the answer, but it does make me anxious. Next one, please. The next catch, and it goes back to one of the comments that Stuart made about people who seem to relapse late, because this virus can come and go. Very early on, we learned with hepatitis C that you catch hepatitis C, you get the RNA, you get the antibodies, and then the RNA can disappear. And it was shown very clearly by Harvey Alter when he followed up people who'd had blood transfusions. There were periods when the virus was negative, the ALT was normal, there was no hepatitis, and then it came back and turned into the chronic form. And I can promise you that all of the doctors, we've all got caught out. You see someone, they're RNA negative, you test them again 6 weeks later, they're RNA negative, you say, don't worry, you've cleared it, don't worry about it. And then 6 months later, they're back, and clearly the virus hadn't gone away. So there are window periods during the early phase of hepatitis C when the virus appears to disappear. And again, we don't know how common that is in people who get reinfected, but simply testing people once may not be enough to catch everybody. Next one, please. And then just to make it even worse, not everybody gets antibodies. And Matthew Cramp did some excellent work down in Plymouth. He took people who'd had a unit of blood from someone that transmitted hepatitis C. That same blood donor had then infected somebody else. And the person in the middle didn't seem to get hepatitis C. And when Matthew looked at those in more detail, what he found was they didn't make antibodies, but they had T-cell responses and slightly unusual responses to the virus. So there are all sorts of odd things that happen when you get exposed to hepatitis C. And how much of that goes on with reinfection, we don't know. Next one, please. So the final important point is we don't know what proportion of people who get exposed go on to get chronic infection. And we don't know how many of those will clear the virus with time. We don't know how many will be negative for a period and then have more virus. And when you think about that for the acute new hepatitis C infection that we know quite a lot about, it gets even worse when we look at reinfection. Next one, please. We simply don't know what happens to people who get reinfected. We don't know how many get symptoms. We don't know how many get enhanced liver damage. We don't know how many are going to be RNA positive and for how long. And absolutely critically, we don't know how many times you can get reinfected. My impression, and it's just an impression, is that we are probably seeing some degree of lesser disease in people who get reinfected. And I say that because we don't seem to see many jaundice patients. We all see patients who seem to have this very low level of hepatitis C, 100 units, 50 units. You think, yeah, you're almost clearing the virus. And we've all seen patients, very often injecting drug users, who are positive for a period, then they're negative, then they're positive again. So I think we should be honest and say we don't quite understand what happens virologically and clinically during reinfection. But the take-home message is that you cannot test too often. And I think we need to be testing people who are putting themselves at risk much more often than we're testing them at the moment. And I think the argument that if we leave some of these people who are RNA positive, they may clear the virus themselves is perfectly valid. But I don't think that's a risk worth taking. I think every time we see someone who's got a bit of RNA, we should be wading in with the tablets and getting rid of it. So my first message is very much keep testing. And when you think you've done enough testing, do a bit more, please. Next slide, please. Ruth's given you some beginnings of an estimate of how many people are reinfected, and the numbers are quite frightening. The estimates vary when you talk around and you look at the published work. They can be as high as 30% in some settings, but more often it's around the less than the 10% mark. And what is absolutely key is that it's the environment, it's the type of drug use, it's the background prevalence of hepatitis C. And the point that I think Stuart and Nathan have made very clearly is it's all about the quality of local drug services to you as an individual. And it's no good setting up services that say 80% of clients get this, that, and the other, and everyone's satisfied. As Nathan said, it's the outliers. It's the people who find it hard to access services. They're the people who we need to be engineering services to meet. Because only when the frequent flyers, the challenging individuals have access to services can we be satisfied that we've got the right service. And I think Stuart's suggestion that we start doing secret Santas and secret shoppers wandering around trying to find out what the service is like is exactly what we want. But I think, Stuart, what you need is some really obstreperous, difficult bugger who makes a fuss in the pharmacy and see what sort of service they get. Because I do think we discriminate against people. If we don't like people, we make life bloody difficult for them. And I often say the only group you can ever discriminate against is drug users and mentally ill. And I think there's a lot of that going on. I do think the key to getting rid of reinfection is going to be better needle exchange, better opiate substitution, and as Nathan said, better support. And that's where the peers can come in. Next one, please. Next slide, please. How do we measure? Oh, sorry, we've drifted on. Go back if you could. If we want to understand reinfection, we've got to measure it. And it's a bit like particle physics. Once you've measured reinfection, it's changed because the people who come back and are tested are not really the people who are at most risk. So what we want to do is test the people who aren't coming in for testing. And that is really difficult. Next one, please. So let's think just for a moment about the groups that we're interested in. We think there's a huge group of people who are in contact with services. They're in needle exchange services, they're in opiate substitution clinics, they're perhaps in prison, they're perhaps in casualty. So those are the contacts where we can get testing. Then we've got the people who are in contact with the people who are attending services. And they're presumably exchanging viruses and exchanging equipment. And then we've got the blue group, the really tricky group, who are absolutely out with services. And all of those groups are exchanging viruses in ways we don't understand, but almost certainly they're all interacting to feed in to the reinfection pathways. Next one, please. So what we've got to do is what we can do, which isn't perfect, because we really want to test all of those groups, including people who aren't in touch with services, and those we can't for obvious reasons. But we must keep testing everyone who's in contact with services. We must retest people who bump into services. I think prisons and casualty testing is an excellent place, and we can't do it often enough. And we've got to try and trace the contacts, because some of those people who are in touch with services will have contacts who aren't. And contact tracing, I think, is going to be a key part of getting to grips with this. Next one, please. So what are we going to do? We need to do more testing, and that testing has got to be paid for, and NHS England is more than happy to do that. We are planning to test around 4,000 individuals every year. That isn't as bad as it sounds. It's about 200 per network, but we don't want the people who are routinely attending, because the people who are routinely attending coming to the clinics are the least likely to be reinfected. So what we're going to do is we're going to go through each of the network's records. We're going to find people at random who've been treated, generally people with a risk factor of injection drug use, and we're going to ask you to feed back the results of their SVR testing. Now, this isn't research. This is what good clinical practice looks like. All we're doing is looking at what's going on in services and encouraging people to do more testing, because we think that's really important. Next one, please. It's a complicated process. And the reason it's a little bit complicated is that if you're allowed to test people and choose, you're going to pick the ones who are easy to test or the ones you think are at risk of reinfection. And that might be the wrong people. It may be the people you least expect who are driving the reinfection, or it might not. So I'm afraid we're not going to allow people to choose who to retest. We're going to choose. And we have to choose as commissioners in a way that keeps the data anonymous, because we're not allowed to know who's who. And that's entirely appropriate. So our data manager, Beatrix, is going to link up with the ODN managers, get a list of patients who've been treated by numbers, not by names. So there's no identifiers. She will then select at random a group of people, feed those back to the manager, who will then go and put names onto the numbers and go find them. Next slide, please. We're going to test 3 times. We want SVR 12. And again, the problem we have is the people we're really wanting are the people who are least likely to have had an SVR 12. So if you just look at people who've had an SVR 12, we're going to get the wrong ones. So we're going to test SVR 12, SVR 24, and SVR 48. Now, depending on how things go, we might extend even further. We might go to 2 years out. We might try and go for 3 years out. But to begin with, we want to try and get a snapshot of what happens in the first year after you've cleared virus. Next slide, please. A key addition, absolutely key, is contacts. We really do want everyone who's reinfected to have a good discussion about contacts. I know that that can be a difficult conversation, and maybe it's a conversation you feel is too threatening to either you as the asker or to the client, who may feel that he's ratting on friends, maybe putting himself into trouble by discussing people he injects with. And if that's the case, we don't want the data. We don't want anyone put at risk. But if you can have the conversation about who are you sharing with, who's giving you needles, who's sharing filters, if you feel able and willing to have that conversation and point us in the direction of other people who are at risk, then that's what we want to do. But we understand that that is a difficult conversation, and we do not want anyone putting themselves or clients or any vulnerable people at risk or exposing people to harm. But if we can start to bring in some of the contacts, we think that would be hugely helpful. Next one, please. So where are we with all of this? Well, we're just wrapping up. It's quite a complicated process, as you can imagine, so we're starting gently. Barts and Leicester are doing a little bit of contact tracing. The peers are poking around and asking awkward questions, and we'll see how that goes. The retesting program has started at Barts. It's a lot of fun working for me. It means you get to try everything out, and then we try and work out where it's going wrong. And then once we've got it working, hopefully we can roll out. And the plan is to start the next 4 or 5 networks within the next couple of weeks. And then by Christmas time, all of the networks will be live, retesting and reporting back. Next, please. Going forwards, it's very clear that a lot more testing is going to have to take place and a lot more linkage of data. And Ruth and her team are currently doing extraordinary things, bringing all the data together. But I think we have to move to a much more centralized system of data collection. We're talking about whether a national registry of hepatitis C patients is something that we can move towards. I'm keen to get feedback on that, but it seems to me that if we can set up a single unified database so that when people have had treatment, wherever they turn up, whether they're in prison, whether in probation services, someone can check whether their hepatitis C status has been assessed recently. They don't need to know where they were tested. They don't need to know whether it was a prison hostel, whether it was in a drug service, but just the fact that they've been tested and are still infected or not infected is the information we need. And of course, that will make national surveillance and picking up of reinfections much more straightforward. So I think we need to think again about how we share data and make it much easier for everyone to know everything if they have a legitimate reason. And there are clearly going to be some issues to work through, and we're clearly going to need some advice and guidance on that. Next one, please. So wrapping up, reinfection is a threat. It really is a threat to the whole programme. I think Stuart made the point that if we clear everyone and then leave a small number of infections to restart the cycle, we could be coming back to hepatitis C in 10 years' time with the numbers at the same rate they are today. So it is a threat and we need to take it seriously. We've got to work out how much of a threat it is, and we have to take steps to mitigate it. And my final plea is please reassure your patient that we are not going to stigmatize them. We are not going to get all stroppy if they reinfect themselves. We're going to give them the tablets. We're going to help them, support them through it. We will always treat people. So please tell them about the risk of reinfection and encourage retesting. And on that, I'm going to hand back to Rachel and Stuart, and we have, I hope, some time for questions. Thank you.
Thank you, Graham. As ever, that was brilliant. And it was kind of the top and the tails, starting with Ruth and the data, and what they're doing, and coming back to yourself with the bit in the middle around, you know, the behavioural and the harm prevention. I think as all of you were speaking, it really is a two-pronged approach, you know, and there's something about, you know, testing being taken out into the communities and happening at point of care. So really following up on what Nathan was saying, you know, being able to do everything, go and finding the patients, but also surely there has to be something around ensuring that testing continues within drug services, continues within prisons. So there's not only about reinfection. So whilst we've got this focus at the moment on reinfection and trying to find out about reinfection, these are things that we need to embed as we move through and eliminate hepatitis C, because if testing's not embedded, if harm prevention's not embedded, you know, and I guess we have to keep coming back to the messages. And when we're working with people, I know at the Trust, you know, we are raising awareness and we're working on a one-to-one, but, you know, we know that if somebody is unwell and they need a hit and they need some heroin, for example, you know, they're going to do whatever they're going to do to make themselves feel better. So I'm just going to look at there doesn't seem to be many questions as such. We have got loads of comments, and I do want to say, just pass this on, Nathan, some great comments about your presentation, how thought-provoking it was. Michelle has said that she was thinking of a personal pack. I guess that's off the back of what you were saying about taking some water with you, a personal pack for going out for the people, people who you're going out and visiting. And then somebody underneath has put, my impression so far is to get the message out there to inform clients that once you've had Hep C, you can still get it again, pinpointing the safer practices that you mentioned, Nathan, really important. But I think for each of you, because there's, on the end, something that Graham was saying there, he was saying about the National Registry for Hepatitis C. Just wanted to get some feedback. Any of you guys here, panelists, what are your views on that, having a Hepatitis C National Registry? Ruth, what do you think? Sorry, throw you in there.
Yeah, no, we discussed it a little bit last week, didn't we? I think there is merits to it. It's just ensuring that it is usable by everyone, not just so, and then we don't reinvent the wheel and have two parallel things happening at the same time, and that we're all joined up. I mean, you know, to go in and be able to identify if the person's been tested recently and all that would be absolutely fantastic. It's just, is that feasible? And, you know, is it that we're going to end up with people, I think last week it was discussed, you know, I tested this person in the car park, anonymous. And so that's not going to help anyone because they're going to look them up and the name's not there or anything. So it's just kind of working together to make that happen. But I see it being a great tool.
Yeah, and Stuart, what about you? What do you think? Oh,
I'm just going to agree with Ruth always, because I do believe that whatever gets done, it gets done with UK HSA, which is the new PHE, who have been monitoring incidents for however long you've been doing it, probably before you worked there, Ruth. And it needs to be joined up, all inclusive. And and I suppose drug services themselves need to be able to feed that.
yeah.
I believe that so there is a treatment registry already. And so whether patients know that they're going on that registry, but they are, and then this is now a testing registry. So there is something about patients understanding that their details could be held somewhere. But it's a good idea.
Nathan, what do you think? I mean, from on the ground level, how do you think it will be received if people knew that they were going to be on a registry? I mean, I have a slight hesitation slightly in terms of what the reception would be. What do you think?
I suppose it depends sort of how it's delivered a lot. You know, if it's that we're going to retain your details so that we can follow up and make sure, check for reinfection and that it hasn't come back. And we explain what Graham was saying, that sometimes it seems like it's gone and it might come back. So we will, your details will be retained so we can find you in the future. Yeah, but I don't see how else you can monitor it and get the data without sort of following it up like that. I mean, it is all the same clients in an area that are going round and round. It's the same people that are in and out of prison. It's the same. Yeah. So yeah, it's easy enough to retest them because we know they are. I mean, people get recovery and sort of, might be in a different place, but we could probably locate most of these clients again.
Yeah, no, I agree. So Graham, I've got a little question here for you. So what plans are there to share and publish the data once this has happened? Have you already started planning that?
Sorry, Rachel, is that for me?
Yes, it was, sorry.
No, very much so, very much so. Data is one of those strange things that the more you share it, the more valuable it gets because everyone adds to it and then it builds up. So once we've got some numbers, we'll put them in the public domain and we'll get comments on them. But if I could just go back to the registry issue, because I think this is probably an idea whose time has come. And it's always been burdened with collecting data about people that included details of their injecting drug habits. And that's always been a reason why people have been nervous about having their information on a database that includes detail of illegal activity. And I can quite understand that. And I think that, going back historically, Stuart may recall the good old days of the addicts register and so forth, which was a very depressing environment where people were really stigmatized. Part of moving
Too young for that, Graham.
Sorry? Delighted to hear it. But I think, in a way, it becomes part of normalizing drug use as a health problem rather than a something to be stigmatized for. And I just wonder if, in the same way that HIV has been normalized, we can start to normalize hepatitis C. A mental health problem is a mental health problem like a physical health problem that requires appropriate healthcare, and that requires joining up. You wouldn't have a diabetic whose foot care and dental work was taken place without access to their diabetic records and stories of their other healthcare problems. So why do we take people with mental health problems, addiction problems, homeless problems, psychosocial problems, and say we've got to keep the data separate? So I think it's part of the normalizing. But I do understand how NHS England sucking data out of addiction services registries, putting it together, parceling it up with UXA is going to be difficult, and we're going to need a lot of education and information. And I have to say that I think UXA, we got to think again about UK health security. I think putting security in there is not going to help this task. And I think going back to old Public Health England, it's a public health registry. It's not a security registry. But I'm keen to get other people's views on how we can badge this, how we can sell this, And then, as Ruth says, there's a lot of background working on how we actually make it work and make it all join up. But I have this sort of vision of everything coming together in a single place. It's, as Stuart said, it's got to be a public health database, not a clinical database. So the prison testing goes in, the probation testing goes in, all the data that is sucked in from the laboratories goes in, and people can enter data as they test. And I think with the right constraints, so that you can only access the key data. You can't find out why people were tested, where they were tested, just the status is all we need. So keen to get feedback from colleagues. And if you want to let me know by email whether you think this is viable or whether you have strong objections, if you have objections, please tell us, because we want to know, we want to understand the issues and the concerns so we can deal with them.
Can I ask, does it have to be called a register? Because like,
No.
you know, like being added to a hepatitis C register, I'm not sure I'd like that, you know, and
yeah, we
so
don't
causing it, like follow up or I don't know, you know, finding a name that's, because, you know, you've got like a sex offenders register and, you know, it's like, I don't know if people would want to be added on a register to sort of know their Hep C status, but if it was for follow up to find out about reinfections or for their own care.
I agree, Nathan. We don't really use register. It has that
Okay.
it has complete different connotations, and everyone gets a bit twitchy, as you say. So if we can come up with an amazing name, let's go for it.
You do use the word surveillance, though, Ruth, which is equally worrying.
Surveillance
All right,
and
I take
register.
your point.
You won't have many people signing up for it.
Yeah. We all see words in a slightly different context. And that's why it's really important that we get the words, because words matter here. And, you know, if we get off on the wrong foot, we're going to kill ourselves with this. So we need to think about a cunning descriptor. I'll leave that to you, Nathan.
Something care friendly, something about helping them.
Absolutely. But it is that thing about everybody being able to input into whatever it is, and accessibility. You know, accessibility of all professionals. So it has to be, I think you've all said that in the presentations, it's about a joined up approach across the board. We don't really have any questions, but I just wondered whether we could touch on the contact tracing, and just a bit further on that, the kind of, so the work that's been done in Tayside, so all the mapping that's been done there. And Stuart, you said, I think that is Ryan Buchanan about to start another piece of work?
I believe he's interested in it and looking at injecting drug users and their networks in Southampton, and possibly the time taken for the prevalence to increase again once you've got it down in a certain group of injecting drug users.
Okay,
but it's very early days,
right? Because I think that there's lots of questions coming in or comments coming in about the register. Sorry. So we can come back to contract tracing just to, somebody said here, would the register be anonymized? I think you already said that, Graham, didn't you? That it would be?
I think to be useful, it's got to have some identifier on it, but it's a question of what identifiers need to be on there, and that needs to be agreed. And I'm trying to catch some of the other comments and questions as well. I like the idea, ODN retesting project.
Yes, and clinical system. Just a clinical system rather than a register is a really good answer. That's Jane Spear.
Petra Wright's asking about those infected by transfusion be included. I can't see any reason at all why not. And likewise, people infected from travel abroad. We certainly, in our community, we've had some reinfections recently from people who went home to Pakistan and had healthcare in Pakistan and then became reinfected. So it's not just the people who inject drugs who are at risk of reinfection. And I think perhaps that's another way of destigmatizing it.
Is there anything that, I just kind of want to throw it back to you guys. We have a bit of time left and there's not a lot of questions coming through. So I wondered if there's anything more that you might like to explore or talk further on? I mean, this is really new. We don't have much information at the moment. I don't know, Ruth, is there anything that you heard kind of from the other presentations that kind of stood out to you?
I think it's really interesting about the holistic bit, you know, and I know we're all going towards that it's not the virus, it's the person. And I think if we can support that, working with you guys as well, if we can identify areas and then with your on the ground peers kind of try to understand what is missing or where there are gaps, as we said, would be invaluable. And if that is about continuing, I know we've already started trying to map NSP and service provisions, but if we can support the numbers and you guys can support with the qualitative for that needs assessment, that would be, I think, would be fantastic. And then going back to the anonymized, I was just writing a note. I think if we are going to do this as a joined up, we can't take away from the fact that we need identifiers to be able to deduplicate and link between systems to monitor our efforts. So I think the anonymization would be more the external users being able to log on what they're allowed to see, but we would still need good identifiers to be able to truly know the number of diagnosed, know the numbers treated and cleared, and then get that reinfection. Because if we anonymize everything, we'll lose the ability to even present what I presented today. So it's just that importance as well. But yeah, it would be great to feed into anything that anyone is working on to give that background information.
Brilliant, thank you. So we've got a comment here from major factor. So from Pete Gibson, a major factor I found that all service users are at the higher risk of infection or reinfection has come from the scaled down harm reduction services that took the brunt of the funding cuts. And I think that's something that you spoke about, Stuart, you know, the funding cuts and the issues that we've seen since then. And so really, and I guess this also leads into, and I think you had a slide on it, Stuart, on the integrated care systems, you know, what's going to be happening with the new systems in terms of commissioning, whether there'll be something from the Dame Carol Black review. I don't know if you want to comment on that, Stuart.
No, I mean, within the group at the Hepatitis C Trust, we know from what we see that there's a massive reduction in harm minimization services, but there's no evidence. And there's no evidence to, you know, real evidence to show what it's doing to our efforts to eliminate hepatitis C. And that's why we've set about thinking about, well, let's go out and survey. And it came from, like I said, the National Needle Exchange Forum, where they wanted to know what sort of service are people actually getting. And we have started to work with researchers who can help us put a survey that would be actually usable. To you know, commissioners, in my experience, they commission on evidence, and it's you know, quite hard to get them to commission on common sense. I suppose maybe it's too risky, but certainly, yeah, there's been a reduction in services, and we're seeing it. We're seeing it in the UAM survey. Like I said, higher wound site infections. Drug-related deaths higher than ever before. And that must be, you know, having an effect on hepatitis C incidence.
Yeah.
I think I would see ICSs as an opportunity because, you know, there is a genuine feeling that this silo approach to healthcare hasn't worked terribly well, and ICSs are an opportunity to try and fix that. So I think you're right, Stuart, we need to collect the data and the evidence, but I wouldn't overthink the amount of data we need. And for me, the headlines are the big figures. Mortality from Hep C is going down, so treatment working. That's point one. Infections and deaths from drug use are going up. Therefore, there's a problem at that end of the pathway, not at the far end of the pathway. And that, I think, is what we can use to drive people's interests. And I think one of the powers that the patient group has is to put forward what you think is good. What does good look like? And then go bang on the door of the ICS commissioners and say, this is what we think good should look like. Let's commission to this. And there are wins here all the way. You know, these highly vulnerable people, I think it's fair to talk about consumers of healthcare because everyone gets the care they need. but certainly they have significant consequences from their multiple medical problems that are much cheaper dealt with at an early stage. And I think we should be driving that message that if we get in early and intervene and help people, then we all win.
Absolutely. But I mean, I think it's not just about us as the patient group, it's about us working with the substance misuse providers, because we're not enough on our own to do this. You know, it's been an ongoing issue for a really long time. And I think when I joined the trust 6 years ago, Stuart, you were already working with commissioners, weren't you? You know, and lobbying for commissioners to invest in more harm prevention, invest to make, you know, needle and syringe provision, testing for Hep C. So this has to be embedded now, completely embedded. Else if we do reach elimination, we're not going to be able to maintain it. Alongside, hopefully by then we'll have some information around reinfections, you know, but it has to be addressed over this, you know, now. We don't have time for it to be rediscussed and rediscussed and rediscussed. It needs to be addressed.
I agree.
I think our reinfection report will be very interesting read. We aren't an academic body, so we don't publish evidence-based, but we have been successful in the past at lobbying based on reports that we've generated. I think Rachel's absolutely right. We need to collaborate with providers of substance misuse services and use that report to push for, you know, better harm min services. But like I said in my presentation, we are relatively small compared to the big providers. But if we can throw something in more to their ammunition, and also I'm hoping still that the Dame Carol Black, there is more to be revealed what comes out of that. But, you know, it will come down to public spending. And that's the you know, that's the final thing in what's needed. It will be funding.
Yeah, there's a comment in here actually around the funding. So it says, this is from Martin Monroe. I think that there's something about the funding for testing in local authority areas where the cost could be met by the local substance misuse treatment budget. I prefer that we weren't trying to balance treatment with screening, so we'd prefer for a Hep C health protection budget to meet the cost for screening. Don't know, what do you think about that, Graham?
I strongly agree, but I think I would go further, and it should be a bloodborne virus screening rather than just Hep C. And it is a matter of frustration to everyone that we put a lot of effort in, but we only test for one virus, although we do occasionally allow ourselves to drift. But just moving forward, we have to see this as part of care in the community rather than hepatitis C, because it doesn't stand up on its own. But if we can link into other community services, then it starts to become part of a health package that's of value for everybody.
I guess it's that word, isn't it, syndemic, because it all ties in, everything, it's all a part. So Nathan, it goes back to, you know, kind of you talking about the, you know, all the multiple issues, you know, the mental health, the you know, with the schizophrenia or other mental health issues, the no housing, the no access, you know, not even a telephone, you know, and it's the multiple layers, it's the syndemic multiple layers that lead to all of this, for us being in the position we're in now, or the individuals being in the positions that they are in. Just looking at the time, we've got a few minutes left. We've basically got 3 minutes. Is there, I'm just going to go around and see, is there anything that, I'm just going to give all of you an opportunity to kind of add on one more thing or say something else at the end. Nathan, is there anything more that you'd like to add on the end?
One of the things that, like, we had this little working group within the Hep C Trust recently about these group of clients, the ones that have never turned up that we know are positive. And, you know, we were talking about that, about funding. I mean, I'm always getting told off for spending too much because I buy people phones and take them a bit of shopping. And, you know, if we could have a budget, you know, for that stuff, I think once we get down to the most chaotic people that have never turned up, having a budget, an individual client budget for each person to get them what they need would be really helpful. And I don't know where that would come from, but you know, they've all got different needs. Maybe they, you know, one of them needs a telephone, one of them we could just take them some food, so they got some food to take their medicine with, you know, different things for each one. But we don't have a budget at the moment, and so I'm sort of, you know, I'm limited in what I can do for them, you know.
And Graham, any last words from you?
No, I think I've said enough, but I think Nathan's comments that we need joined up patient-centered budgets is the right thing to do.
I'm sure there was an idea to do that many years ago and it never came to fruition, probably about 20 years ago, but who knows. Ruth, what about you? Anything that you'd like to finish on?
No, I think we really drilled down into some of the big questions, and it's been really informative. Thank you, guys.
No, thank you. And Stuart, anything from you?
No, nothing to add. Thank you to Ruth again for drilling through those huge amount of numbers and trying to make sense of a very messy situation. And thanks, Nathan. Fantastic presentation. Thank you, Graham, as ever. I've got a quick question for Graham. I wrote down here, I used to tell people if that they hadn't cleared the virus naturally, in inverted commas, within 6 months, that they wouldn't clear it. And something you said made me question that. And I kind of knew that there was some outlying cases, but I used to say that because I met so many people who were adverse to treatment and would rather see how the virus took its course and that hopefully it would clear maybe 2 years later, 4 years later. Something you said made me question that.
95, 96, 97% will be clear within 6 months, Stuart. You're absolutely right. So you're putting your money on a winning horse, but there's always these few. The tail is longer. One of the problems is the tail, of course, depends on individuals. It may be that they're getting reinfected. Margaret Hellard's put a lot of work into looking at reinfections in people who inject drugs. And if you're in a closed community, you can share the same virus. So even viral sequencing may be fairly similar, but they keep getting infected from the same group. So a lot of unknowns. But I think the delving down into the minutiae is probably not where we want to go. The headline is keep testing. If you're positive, take the tablets, it'll go away. And I think that's a nice, simple, clean message that we need to keep getting through.
Okay, so I just want to say thank you very much to everybody. It feels like we've begun a conversation, laid the foundation. Thank you, as Stuart said, Ruth, to you and Graham. Ruth for the stats, Graham for the work that's coming forward. Nathan, brilliant to hear the human, I guess it's the human, sobering reality of the work that we're doing. And Stuart, thank you for all the background on the reinfections report that's coming. A great session, and I would imagine in a few months' time we'll be asking you all to come back again and tell us where we're at. So thank you all very much. I hope everybody's enjoyed the session, and yeah, thank you.